Welcome back to Decode Healthcare with Harshal. Today we are hitting part 67 of our 100-part ICD-10-CM guideline series, and we're going deep today, mastering Section 3 and those tricky present on admission flags. Listen, if you want to know exactly how to report secondary diagnoses on inpatient claims without falling into some pretty devastating audit traps, well, you're absolutely in the right place.
We've got a seriously packed agenda for this explainer. We're going from the foundational hierarchy through the 5 UHDS criteria, how to handle incidental findings, decoding the POA matrix, and finally, surviving the HACE financial trap. All right, let's jump right in.
Section 1. The medical coding hierarchy, where CMS guidelines strictly overrule the textbooks.
And Section 2, we're looking at the 5 UHDS criteria and their mandatory thresholds.
Okay, before we get too deep into the weeds, we need to establish the absolute golden rule of medical coding. The CMS ICD-10-CM official guidelines, they strictly override any textbook. Yeah, even Buck's step-by-step. As expert coders, our ultimate source of truth is always CMS. Textbooks are great for learning, sure, but CMS guidelines are the actual literal laws of medical coding. And that brings us right into Section 3, reporting additional diagnoses. The Uniform Hospital Discharge Dataset, or UHDDS for short, defines secondary diagnoses purely based on whether they actively affect patient care during the stay. Basically, it includes all conditions that coexist at the time of admission, anything that develops later, or anything that impacts treatment and length of stay. In the real world, this is the hard dividing line between what a physician just casually jots down in a chart and what we legally report to the payer. But how do we actually prove to an auditor that a condition affected their care?
That is exactly where these mandatory thresholds come in. For any coexisting condition to be reportable, it absolutely must, and I mean must, trigger at least one of these 5 pillars. You always have to ask yourself, did it require a clinical evaluation? Was therapeutic treatment given? Did they run diagnostic procedures specifically for it? Did it extend the hospital stay? Or did it require increased nursing care or monitoring? If a condition doesn't hit at least one of those 5 marks, it doesn't belong on your claim form, period. We aren't here to code every single ailment a patient has ever had since birth, right? We're here to code what actively consumed facility resources during this specific encounter.
Moving on to Section 3, omitting incidental findings. This is all about the rule of exclusion.
You know, knowing what to exclude is just as crucial as knowing what to include. Let's think about a historical condition or an incidental finding. Take controlled, asymptomatic, mild hypertension, for example. If the patient is just taking their usual meds from home and needs absolutely no new medication changes or extra monitoring while admitted, well, that condition fails all 5 UHDS criteria. Since there's no active evaluation or extra treatment, you omit it. Just completely leave it off. But, and here's the flip side, if that exact same hypertension suddenly spiked and required a new IV med or active telemetry or maybe a cardiology consult, boom, it triggers the criteria. In that case, it ate up hospital resources, so you absolutely code it. So a huge point of friction here is how we handle abnormal lab results. Look, these cannot be coded automatically just because they pop up in red on a chart. Let's say a patient has slightly low potassium on a routine panel. You're an expert coder, right? Not a clinician. You literally cannot diagnose hypokalemia purely based on a lab value. The provider has to explicitly state the clinical significance of that abnormal lab in the record, tie it to a diagnosis, and they still have to treat or evaluate it to meet those UHDDS criteria. You just have to sit tight and wait for the provider to make that explicit link before it ever touches the claim. All right, Section 4, decoding the POA matrix and those present on admission guidelines. Now that we know what gets coded, we have to determine exactly when it happened using Appendix I, the present on admission, or POA guidelines. Honestly, you've just got to memorize this matrix of the 5 official CMS POA indicators. Y is yes, meaning the condition was present at the exact moment the inpatient admission order occurred. N is no, it wasn't present, so it developed after admission. Then we've got U for unknown. You use U when the documentation is just, well, insufficient or sloppy, making it impossible to tell. Now contrast that with W, clinically undetermined. W means the provider is medically unable to make the call, regardless of how great the documentation is. And finally, 1 means exempt. That's for specific codes, like congenital anomalies, that are legally exempt from POA reporting altogether. To really see why precision matters here, let's look at a timeline. Imagine a patient is admitted on day 1 with a stage 1 pressure ulcer. By day 4, it deteriorates into a stage 3 ulcer.
POA-Y definitely applies to the stage 1 ulcer at admission, but the progression logic requires careful POA mapping for the highest stage, so you'd actually report the stage 3 ulcer with a POA flag of N. Why? Because that specific severe stage 3 condition was not present when they walked through the doors, it worsened under the facility's care.
So in practice, pre-admission pneumonia confidently gets a Y. They brought the infection in with them. But for a postoperative catheter-associated UTI that showed up on day 3, we have to hit N. It's just a simple little letter, right? But the consequences of assigning that N are massive. It completely shifts the narrative from we treated what they brought in to they suffered a complication because of us.
Which brings us to Section 5, the HAC financial trap and the reality of quality audits. This is where the financial stakes get incredibly high. The government is watching these flags like a hawk. Medicare and commercial payers aggressively audit cases where a preventable condition gets flagged with an N because that classifies it as a hospital-acquired condition, or a HAC. By assigning an N to something preventable, like a stage 3 or 4 pressure ulcer, a catheter UTI, or an inpatient fall, you're explicitly telling the payer, hey, this injury happened on our watch. And frankly, payers refuse to foot the bill for a hospital's mistakes or poor infection control. No way. When a HAC is triggered, it's a domino effect. CMS acts immediately to strip away the complication or major complication, the CC or MCC, reimbursement weight. They simply will not pay you extra to treat a complication your facility caused. This downgrades the entire MSDRG claim. But it doesn't stop there. Consistently triggering HACs puts the hospital on quality penalty lists. That haunts the facility's reputation, publicly tanks their quality scores, and aggressively drains the bottom line for years.
An improper assignment of N instead of Y, maybe just because a rush doctor didn't document that a severe condition was actually present on admission, can literally result in a 100% loss of that MSDRG severity bump. 100%. Your reimbursement drops from high severity all the way down to base severity. We're talking thousands of dollars vaporized on a single claim just because of one missing letter or a sloppy chart. Multiply that error by hundreds of patients a year, that's devastating for a facility, and it's entirely avoidable.
So as we wrap up this explainer, I want you to take a hard look at your medical records. Is incomplete clinical documentation secretly draining your hospital's bottom line? It's up to us to query our providers, master these UHGDS guidelines, and assign our POA flags with total precision. Thanks so much for diving into Section 3 with me today, and I will catch you in the next explainer.